Welcome to this explainer. Today, we're climbing what surgeons call the reconstructive ladder. We'll be exploring some high-yield clinical principles, going all the way from acute trauma right up to some incredibly delicate aesthetic refinements. So let's jump straight in. We're tackling 4 critical domains today: trauma and tissue repair, congenital hand syndactyly, cleft lip and palate, and finally facial plastics and reconstruction. Starting right off with Section 1, trauma and tissue repair. Okay, imagine you're faced with a classic high-stakes clinical scenario. You've got to handle a traumatically amputated digit. When you evaluate the preservation methods, the absolute correct move, option C, is to prep and wrap the amputated specimen in moistened gauze. The actual physiology behind this choice is just fascinating. Optimal preservation means sealing that moistened specimen in a waterproof pouch and cooling it in an ice-water slurry. By dropping the temperature to exactly 4 degrees Celsius, you induce cold ischemia, and that actually extends the viable replantation window up to 24 hours. But here's the kicker: never ever use formalin or antiseptics. Doing that literally fixes the structural proteins and destroys absolutely any chance you had of microvascular salvage. Moving a bit deeper into tissue repair, let's talk about tendons. How much time is actually required for a tendon to heal after a surgical repair? If you guessed 6 weeks, option E, you're spot on. Tendon healing is really all about physiological patience. You see, those first 4 weeks are a highly delicate fibroblastic phase. The tissue is incredibly vulnerable to rupture during this time. But then, right around week 6, the repaired tendon interface achieves this massive 3-fold surge in tensile strength. It's only at that specific point that you can safely start robust physiological mobilization. Now, let's think about nerve repair. Say a patient undergoes an ulnar nerve repair. How do we clinically assess the recovery of that nerve growth? We rely on the Tinel test, option B. This classic clinical test lets us essentially track microscopic physiological progress right beneath the skin.
And here is exactly why it works. Lightly percussing along the tract will elicit distal paresthesia exactly at the active site of axonal growth. A healthy nerve is going to regenerate at a very predictable rate of 1 millimeter per day. But you have to watch out. If you notice a stationary Tinel sign over serial follow-ups, that's a huge red flag. It tells you there's an internal block or an aroma, meaning surgical re-exploration is definitely required.
Moving on to Section 2, congenital hand syndactyly. When we apply these reconstructive principles to congenital anomalies, what's the most common type of syndactyly? It's option A, the middle ring finger fusion. When babies are born with fused digits, the statistical majority are going to involve this specific web space.
So, while the third space between the middle and ring fingers accounts for about 50% of cases, consider the first space, the thumb-index fusion. Even though it's the least common, sitting at only 5%, it carries the absolute highest surgical priority. It's a clinical emergency that has to be released before 6 months of age to prevent permanent structural growth suppression.
Let's transition over to Section 3, cleft lip and palate.
Looking at pediatric facial growth, what is the most common subgroup of cleft presentation? It's actually option C, a combined cleft lip and palate. Congenital facial clefting comes in several isolated variations, sure, but the combined presentation is the one you'll encounter most frequently.
In fact, 45% of these infants present with a combined deformity. This makes it a huge central focus of pediatric reconstructive planning, which leads us directly into the absolutely critical question of timing.
Because, let's face it, timing is everything in pediatric surgery. So, what is the optimal time to repair a unilateral cleft lip? The physiological sweet spot is option B, 5 to 6 months. This perfectly balances the infant's overall growth with a need for precise muscle realignment. If we follow the modern Dallaire sequence, these repairs are systematically staged out. Bilateral lips are repaired slightly earlier, usually at 4 to 5 months, and unilateral lips at 5 to 6 months. Crucially, the palate needs to be closed between 6 and 12 months. Getting this done ensures proper anatomical function before the child starts speaking, which prevents severe speech delays down the line.
And finally, Section 4, facial plastics and reconstruction.
Diving right into elective procedures here, what material typically makes up a chin implant? The answer is option A, silicone. When performing craniofacial augmentations, like a mentoplasty, biocompatibility is absolutely paramount. That makes silicone the most widely utilized choice by far.
Now, there's a really fascinating clinical trade-off between implant materials. Smooth silicone is biologically inert. It just sits there in a stable fibrous capsule without actually integrating, which makes it incredibly easy to remove surgically if needed. On the flip side, porous materials like Gore-Tex physically facilitate active host tissue ingrowth. That offers extreme stability, but it makes them significantly harder to explant later on.
Moving up to the upper face. What's a suitable option for reconstructing a partial thickness upper eyelid defect involving 50% of the lid? Option A, primary closure. Eyelid reconstruction requires strict adherence to very specific anatomical algorithms.
Consider how the surgical complexity dramatically escalates the second a defect crosses that 50% threshold. Up to 50% partial thickness, and you've got enough laxity for primary closure with local tissue advancement. But greater than 50%? Suddenly you're looking at a full-thickness skin graft from the contralateral eyelid. It's a real game changer.
Okay, last question. How do we address aesthetic complications? If a post-facelift patient comes in with skin slough in the post-auricular area, the best management is actually option E, minimal debridement, antibiotic cream, and allowing healing by secondary intention. Honestly, sometimes the hardest lesson for a surgeon is learning when not to cut.
Because the head and neck have such an incredibly robust collateral blood supply, conservative management is often the hero here. Aggressive debridement would just disrupt the viable dermis and actually worsen the scarring. Allowing the area to heal by secondary intention yields a far superior aesthetic outcome than doing an aggressive skin graft.
So, from replanting severed digits in ice water to meticulously guiding facial healing by secondary intention, it all leaves us with a fascinating question. Does our growing mastery of tissue physiology make the reconstructive ladder limitless? It's an incredible thought about the future of healing. Thank you so much for climbing the ladder with me on this explainer today.